diagnosis, diagnosis and staging of HCC, surgical, locoregional, and systemic therapies for hepatocellular carcinoma, in particular with a focus on sequential therapy strategies. And finally, conclusion. In spite of the eradication of the viral etiologies of liver cirrhosis, we are experiencing still an increase, a steady increase in the incidence of hepatocellular carcinoma and in general liver cancer worldwide, in particular in Western world. These are the last data. In my region, Southern Europe, we still have a high high incidence of hepatocellular carcinoma. And as you can see, there is still an increase in the incidence. We know that viral etiologies are decreasing in incidence, but we are experiencing a sharp increase in the occurrence of metabolic related liver disease, chronic liver disease, such as NASH, and hepatocellular carcinoma occurring in NASH patients. These are the main risk factors for hepatocellular carcinoma. Basically, all etiologies, regardless of etiologies, liver cirrhosis is a predisposing factor for the occurrence of hepatocellular carcinoma, with a particular attention on HBV, because the DNA viral genome of HBV can be integrated into the host cell, hepatocyte cell, and so with a direct oncogenic effect due to the virus. But we have also some protective factors. Of course, all therapies, all intervention against viruses, vaccination for HBV, treatment for HCV, HBV are protective factors against hepatocellular carcinoma, but also other drugs such as statins, in particular lipophilic statins, aspirin, metformin, and other factors. Let's see some examples. This is a meta-analysis we published 2 years ago on it was an update of a previous meta-analysis published in Gastroenterology on the effect of chronic statin use on the decrease of hepatocellular carcinoma incidence. As you can see, it's quite blurred, the figure, but maybe you can see the odds ratio is 0.59. So this means that statin users experience a 41% decrease in hepatocellular carcinoma incidence. Adjusting for several confounding factors, the odds ratio is still significant. When the confidence interval is below or up 1, beyond 1, so it does not include 1, it means that the result is significant. So statins are protective factors against hepatocellular carcinoma. This is clear. But also aspirin. This is an interesting randomized control trial published 2 years ago, less than 2 years ago in New England Journal of Medicine. There is a clear difference between aspirin use and no aspirin use. Of course, the difference is significant. This is a meta-analysis of our group published just 1 month ago on the effect of hepatocellular carcinoma incidence in patients with non-alcoholic fatty liver disease, regardless of liver cirrhosis. Still a significant difference, 1.88. So the risk for hepatocellular carcinoma incidence is increased by 88%, so very high, nearly double the risk of non-NAFLD patients. This means also that all intervention directed against obesity may have a protective effect against hepatocellular carcinoma by an indirect effect. This is an interesting meta-analysis we published on the effect of bariatric surgery on the incidence of hepatocellular carcinoma. Still a significant difference in favor of bariatric surgery. Of course, this effect is observed many years, 8, 10, more than 10 years after surgery, but still it's a clear, significant effect. So fighting against obesity, among many other important effects, also shows an interesting effect against hepatocellular carcinoma incidence. Everything we are talking about is about primary prevention. So prevention of liver cirrhosis. This is the primary prevention. Once cirrhosis occurs, we are just in the field of secondary prevention, that is, it's less effective. And finally, tertiary prevention is against tumor recurrence. I will cite frequently the recent EASL guidelines. So antiviral therapy, DAAs against HCV, are effective in preventing cirrhosis progression, so also HCC incidence. But probably you know that 5-6 years ago, there was a great debate on the potential effect, oncogenic effect of these drugs in favor of HCC, in particular HCC recurrence. And there was a great debate with some concerns on this effect, and still we have some doubts. At that time, we published an interesting laboratory study that demonstrated that during therapy, as you can see, therapy with DAAs, there was a sharp, significant increase in several growth factors, so pro-tumorigenic factors, such as vascular endothelial growth factor, EGF also, that was at the top level at the end of therapy. And then after therapy, there was a decrease to the baseline level. So this increase may be responsible of a higher tumor recurrence. So we still have some concerns on this regard. HCC screening. HCC screening is conducted with ultrasound and alpha-fetoprotein at 6-month interval. Other options were tested, such as the fraction L3 of alpha-fetoprotein, this gamma carboxyprothrombin, but these markers were not so effective. They just increased the cost. HCC screening is justified when HCC incidence is beyond 1.5% a year, and is justified in patients with child-pug stage A and B, child-pug stage C only if in a liver transplant list, because of course, as you know, patients, child-pug C patient not amenable to liver transplantation are not suitable to any anti-HCC treatment. So even if we are able to detect early the tumor, we are not able to treat. So the screening is useless. Non-cirrhotic HBV patient, due to the aforementioned characteristics of HBV to integrate the genome into the host cell, some doubts, as you can see, low quality evidence, weak recommendation in non-cirrhotic F3 patient due to the other causes. This is the diagnostic algorithm. If we have a nodule less than 1 centimeter, we will be likely not able to conduct a good diagnosis. So the suggestion is to repeat ultrasound at 4 months. If stable, okay, we go back to the normal screening. If there is a growth in the tumor sites, we fall in the other category. It's useless to risk a liver biopsy in this case due to the high risk of inconclusive diagnosis due to the small tumor size. If we have a nodule more than 1 centimeter, if we have a clear diagnostic imaging hallmark for HCC at CT scan or MRI, so quick wash-in and rapid wash-out in the porthophase, in this case, we have the diagnosis. Otherwise, we should try another diagnostic tool. So if we conducted CT scan, now MRI or vice versa. And so if we have diagnosis good, if we still have some doubts, biopsy. So you see that the role of liver biopsy is very, very limited in the diagnostic algorithm of HCC. Staging. You know that all tumors follow the TNM stage. And we have TNM also for hepatocellular carcinoma, but it's not enough. because patients with hepatocellular carcinoma present two liver diseases, the tumor and the cirrhosis. So as we will see, liver cirrhosis is the main prognostic factor in this patient because influence very strictly the therapeutic algorithm. So a staging system should include both situations, liver function and tumoral stage, in addition to other factors such as performance status and so on. And this is possible with the BCLC, Barcelona Clinic Liver Cancer staging system. Very early stage, BCLC 0, single nodule less than 2 centimeters with preserved liver function. Therapy, ablation, or resection. Early stage, BCLC A, single nodule more than 2 centimeters or up to 3 nodules less than 3 centimeters each. And in this case, we can have liver transplant or ablation or resection. We will see later each situation. Up to BCLC A, we still have a chance to cure our patients. But if we are in the stage of BCLC B or beyond, we can have only palliative treatments, such as chemoembolization in the case of intermediate stage, so multinodular disease without portal vein thrombosis, or advanced stage, BCLCC, so tumor with extrahepatic metastatic spread or tumoral portal vein thrombosis. Finally, we have BCLC-D, terminal stage, regardless of tumoral stage, deteriorated liver function or end-stage performance status, in this case, only basic life support. These patients are not amenable of any treatment against hepatocellular carcinoma. Let's see more specifically one by one. BCLC 0, very early stage, single nodule less than 2 centimeters, so very early tumor. Therapeutic option, surgical resection if feasible, or ablative treatment. Be careful that BCLC 0 stage does not give additional MEL points in provision of liver transplantation. Surgery is the mainstay of HCC treatment. But as you can see, after these radical therapies, a 5-year recurrence is still high. A 5-year survival is not that high as we can expect with a curative treatment. Now surgical center prefer to use laparoscopic liver resection rather than open liver resection. This was in our study of our group when I worked in Milan nearly 10 years ago. I'm getting old now. So duration of hospital stay was in favor of laparoscopic surgery, such as also rate of complications. So laparoscopic surgery should be preferred. This is another important study we performed those happy days when I worked there. And this diagram is included in the current EASL guidelines. So if you check the guidelines, you find this diagram from our study. This is a quite complex statistical model based on a recursive partitioning analysis that identify different risk classes for post-liver resection decompensation. So if we have a patient without portal hypertension and undergoing minor hepatectomy, so only the segment with the tumor, and MEL score less than 9, no more than 9, in this case, the risk of decompensation is very low, less than 5%. So we can perform surgery safely. If we have, on the other hand, portal hypertension, major hepatectomy, the risk is too high. The risk of liver decompensation is 60%. So we should absolutely avoid surgery. So we should try other therapies such as ablative therapies. In the middle part, we should evaluate time after time. We have up to 30% risk, so non-negligible risk of liver decompensation. So the indication should be discussed in a multidisciplinary setting. Okay, about neoadjuvant therapies, we will talk at the end of the lesson. But for now, keep in mind that tumor recurrence, even after surgery, is very, very high. 70% of cases at 5 years. So very, very high. Why it's so high? Because even if we are able to cure effectively the tumor, liver cirrhosis represents a protumorogenic milieu for the occurrence of many other tumoral nodules. So we can have recurrences, not real recurrences of the first tumor, but de novo tumors, newer tumors that we should be able to cure. So it's a very difficult situation. Local ablation, yes, in very early stage represents a good therapeutical option with very good results. This was an old Italian study published in Hepatology in 2008, was the first study to demonstrate that in very early stage BCLC 0 patients, radiofrequency ablation present more or less the same results as surgical resection. So we could consider safely radiofrequency ablation that does not present all those aforementioned risks for liver decompensation. These are the main ablative treatment. The most used are radiofrequency ablation, microwave ablation. Microwave ablation generates a wider necrotic area. So we should be very careful because the risk of vessel damage or the risk of liver decompensation is higher. But also microwave ablation can be more effective in the presence of wider tumor. Cryoablation, honestly, I don't have experience and it's not performed in Italy frequently. To the best of my knowledge, I remember only a single Chinese randomized trial was published 10 years ago, more or less, in hepatology testing these ablation therapies. So the two most important are radiofrequency ablation and microwave ablation. This was a meta-analysis we published 1 year ago, last year, comparison between microwave ablation versus radiofrequency ablation, same results, as you can see, confidence interval crossing 1, so same result, but 5-year disease-free survival rate was much higher, significantly higher with microwave ablation. Adverse event, similar. Let's say that with the current evidence, we cannot prefer one treatment over the other. So both are effective. In the last year, there's a growing amount of data on stereotactic body radiotherapy, so external beam radiotherapy. This is a meta-analysis we published on comparison against radiofrequency ablation. Again, non-significant result in terms of survival rate, but recurrence-free survival rate was significantly higher 2 and 3 years with radiotherapy. But also be careful that adverse event rate was much higher with radiotherapy. So radiotherapy can be an option only in experienced center, in high volume center. Sorry, I switch on the air because I'm melting here. We have more than 40 degrees in Italy. So early stage BCLC-A, single nodule more than 2 centimeters or up to 3 nodule less than 3 centimeters. Therapeutic option. When feasible, liver transplantation. Otherwise, if the tumor nodules are on the same segment or adjacent segment, surgical resection or even ablation, TACE if we have a more difficult situation. Liver transplantation is recommended as the first line option within Milan criteria, because liver transplantation, remember that it's the only therapy able to cure both liver disease, both tumor and liver cirrhosis, the only therapy able to do that, so decreasing significantly the risk of tumor recurrence. This is an Italian pride of Italian science, because when this paper was published by the group of Professor Mazzaferro, where I had the pride to work 10 years ago in Milan, it was in 1996, New England Journal of Medicine. Until 1996, if we had this talk more than 25 years ago, In this case, we should say that liver transplantation is contraindicated in patient with hepatocellular carcinoma. Any situation was tried with very, very bad effects. In 1996, Mazzaferro and this group say two important things. One, liver transplantation in selected patients not only is not contraindicated, but represent the most important therapy for hepatocellular carcinoma, most effective therapy. Second, they fixed the criteria, the so-called Milan criteria, single nodule less than 5 centimeters or up to 3 nodules less than 3 centimeters. In this case, 5-year survival rate is very high, not different from the general population. The problem is that these criteria are too restrictive. And so many patients will fall out of this criteria and will not be treated. Many groups tried to expand this criteria. The same group tried 10 years later, more than 10 years later, to expand with this interesting up to 7 criteria with the concept of metro ticket. As you know, in big cities with the same metro ticket, you can travel in different places within a same area. So the concept is the same. If the summary of number of nodules and max size of the tumoral nodule is 7, so 3 nodules up to 4 centimeters, 2 nodules up to 5 centimeters, 1 nodule up to 6 centimeters, the recurrence risk and the survival is the same, and it's still favorable. Beyond these criteria, liver transplantation should be contraindicated due to the excessive risk of recurrence. Remember that tumor recurrence after liver transplantation present a very dismal prognosis due to the immune suppression of the drugs that transplanted patients take. All the recurrences I saw after liver transplantation, in all cases, patients died within 5-6 months. So we should absolutely avoid this situation. Also because in this case, we waste an organ. I don't know how is the situation in Russia, but worldwide, we have a shortage of liver organs for transplantation. So we should be very, very careful when we use them. What to do if we have a patient out of Milan criteria? We should tell this patient, no, you will never be transplanted. No, this is an important trial published in Lancet Oncology, again by the Milan group, that demonstrate that tumor downstaging is effective. So if we have a patient Milan out, we can try to make the patient Milan in. So we use TACE, we use ablation, we use, even if possible, resection. And if the patient fall within Milan criteria after the treatment, she can be transplanted with very favorable effects as demonstrated in this trial. So even the guidelines recommend locoregional, in particular locoregional treatment as downstaging therapies in the pre-transplant setting. Intermediate stage, BCLC-B, multifocal disease without portal vein thrombosis. Cure is not feasible anymore in this stage and in more advanced stage. Standard of care, so the objective is palliation. Standard of care is TACE, transarterial chemembolization, but we have also other therapeutic options, in particular transarterial radioembolization. 5-year survival rate was very, very short in the first study with TACE, no more than 18 months, but now we have more than 5-6 years of overall survival after TACE. So the guidelines, TACE is recommended for patients with BCLC stage B patient. We should prefer drug-eluting beads or conventional TACE. We will see later that there is no difference as stated in the guidelines. Transarterial radioembolization, I don't know if you know this therapy, is a form of brachytherapy with injection of microparticle not able to embolize the feeding vessel, tumoral feeding vessel. So it's not a true embolization, but these particles are loaded with yttrium-90, so they exert a radiotherapy over time, and it's very effective with very large necrotic area. These are the different survival rates from the first study in 2002 after 10 years up to 5-6 years. Repeating TACE, this is another important aspect. TACE can be repeated, but how many times? We should apply an on-demand schedule driven by response to previous cycle TACE. So we perform first TACE, we see the response. If we don't have a complete response, we perform a second TACE. If we don't have response, we should consider switching to other therapies. In order to decide, to prepare a patient-tailored strategy, several scores have been proposed. This was the score proposed by the Vienna group 10 years ago, the ART score, an objective point score considering 3 parameters after TACE parameter, child-pug score increase after TACE, AST increase more than 25% after TACE, a radiological tumor response. So we have a summary score, and if the summary score is lower than 1.5, it's worthwhile to go on with several other TACE sessions. And this assessment can be repeated after each TACE session. So you see the survival curve is very favorable after several TACE repetition. If we have a summary score more than 2.5, it's not good to go on with TACE, and we should immediately switch to other therapies. We still don't know if the effect of TACE is due just to embolization of the tumoral feeding vessel, or also for the chemotherapeutic agent injected locally into the tumor. This was a meta-analysis we published 5 years ago comparing transarterial chemoembolization, so with chemotherapy injection, versus blunt embolization, so only embolization without any drug injected. And we did not find any difference. I am still convinced after 5 years that the chemotherapeutic injected exerts no effect in this patient. The effect is due just to the embolization. This is my firm conviction. In the last 10-15 years, drug-eluting beads have been introduced in the clinical practice. So microparticle with different sites preloaded with drug, usually doxorubicin. The main problem of conventional TACE is that it's not standardized. So we are not sure how much drug will go into the tumor. Theoretically, this problem is overcome. This issue is should be solved with drug-eluting beads. However, the Precision-5 trial did not find a significant increase in objective and complete response, just a difference in systemic toxicity that honestly is quite rare, uncommon after TACE. The large Italian Precision Italy study performed by the Bologna group was prematurely stopped for futility at the second interim analysis because the investigator did not find any difference between conventional TACE and DAB TACE. So honestly, I don't think that DAB TACE, that is much more expensive than conventional TACE, should be preferred. This is our retrospective experience. This was my residency thesis. And we found even a significant increase in time to progression in the case of conventional TACE. So conventional TACE performed even slightly better, even though without a significant difference in overall survival, rather than DAB TACE. So honestly, I will not spend money for the use of DAB TACE. And this is the meta-analysis we published. Again, no difference between the two treatments, DAB TACE and C-TACE. Newer, smaller beads have been tested. This was a prospective pilot study we published in Milan with interesting result with the M1 smaller particle, but it should be still validated. Resection can be still an option in BCLC-B patient, but in very selected cases, this was an old randomized trial published in Journal of Hepatology by a Chinese group. But as you can see, there was a significant difference in liver function, not significant, but close to the significant threshold in liver function and tumoral diameter. So honestly, I think this trial that was not validated elsewhere present many biases. However, the question, okay, in resectable patient, resection can be an option with a significant result, but how many BCLC-B patients are really resectable? Probably the answer is very, very few patients. Instead, radioembolization represents a good alternative to TACE. This was the prospective study published by the Milan group. And this is an example for a patient that I was in charge of myself when I was in Milan. He presented a huge tumor occupying the whole right lobe. As you can see, after just one TARE treatment, the tumor was nearly out. This is a necrotic area, and we have a very favorable response. Of course, not all patients present this very favorable response, but it may happen. Consider that areas of necrosis are much larger, and the risk of decompensation is higher. So if in the case of TACE, we could still try TACE in patients in BCLC B7 without ascites. In the case of radioembolization, we should be very strict with the indication, considering only child-pug A patient. And also another suggestion, in the case of TACE, tumor response and eventual toxicity are observed within 1 month, 1.5 months after treatment. In the case of TARE, we should wait for the degradation of the radioisotope. So we should wait at least 3 months up to 6 months, 6 months for the response and also for the eventual toxicity. So if you treat a patient now in July, you should wait until December, the autumn, to see the eventual response and the eventual toxicity also. This is a retrospective comparison from the referral group, the Chicago group, comparing TARE and TACE in BCLC-B patient. In selected patient, TARE can perform even better in terms of time to progression. So TARE provides higher response rate, not significantly, with a more favorable safety profile, but a randomized study aimed at comparing the two treatment would require a huge sample size due to the very limited difference between the two treatments. And this is a meta-analysis we published on this topic. We found a significant increase in terms of progression, 1 year short-term progression-free survival in TARE patient, but not a difference in overall survival. Now, for systemic therapies. If we had this presentation 4 or 5 years ago, it will be very quick because we should say something about sorafenib stop. In the last 4 or 5 years, we have several new weapons in systemic therapies against hepatocellular carcinoma. The general principle are that these therapies should be restricted only to patients with well-preserved liver function, so child-pug A patients. This is the progression from sorafenib, approved with a short trial in 2008. And now in the last 5 years, we have a huge number of new molecules, not all still approved worldwide. Most relevant phase 3 trials in first line, so we are talking now about first line therapy. The SHARP trial, sorafenib versus placebo, REFLECT trial, lenvatinib versus sorafenib, and the very recent IMbrave1 trial, atezolizumab, an immune checkpoint inhibitor, plus bevacizumab, anti-VEGF drug, versus sorafenib. This is the future against hepatocellular carcinoma. These are the results with sorafenib in the SHARP trial, confirming the Asia Pacific trial. You see how, I don't know if there is some oncologist among you. They are very weird people because they approve and they make us spend a lot of money with just 3 months difference in overall survival. However, this 3 months difference in comparison to placebo is still significant. The mechanism of action of sorafenib is not selective. Sorafenib acts against a number of molecular targets, VEGF, PDGF, and RAF, RAS pathways, so it's not selective at all. And this is why this is why sure sorafenib has a lot of adverse events. The median overall survival is around 1 year in all the trial, more or less. Treatment effects, the most important in my experience are fatigue, dermatological effect, in particular, and foot skin reaction, diarrhea, and liver function deterioration. These are the most important facts that may lead to treatment interruption or underdosage. However, it was demonstrated first by the Barcelona group, but we confirmed in our study the same result, that adverse events, in particular dermatological adverse events, are correlated with better outcomes, better response. It means that the drug works better in this patient. And this is quite true for more or less all oncological therapies. In the past, 10 years ago, less than 10 years ago, several groups, and also the Milan group where I worked at that time, tried to find a molecular signature, such as in the pancreatic cancer, colorectal cancer, breast cancer, molecular signature to have a tailored therapy. Sorafenib is not a target therapy. We use sorafenib to all patients without knowing beforehand if that drug will be effective or not. And the same we will see it's also with the newer drug for hepatocellular carcinoma. We try to find a target therapy. A lot of debate was about this drug, tivantinib, proposed studied by an Italian oncologist working in the United States. It performed quite well in first-line study, but in the phase 3 trial, it was not superior to placebo, so a big failure. I participated to the trial testing rifametinib, a drug that seemed effective, but the problem was that the molecular signature that represented the indication to rifametinib was present just in 5% of patients. So when I screened, all the patients were screened out because they do not present the correct mutation. So it was another big failure. In spite of this big failure, we still kept on going on with these molecular targeted drugs, but there were, as you can see, this like great expectation, but even higher disappointments. But as your great poet Alexander Pushkin said, the deception that elevated us is dearer than a host of low truths. So we still were sticked to this idea of the, in spite of all the deception, to this idea of the molecular target. It was a fascinating idea, but as you can see in this slide, a great disappointment. This curve, Kaplan-Meier curve, is the death for any oncologist, no difference as compared to placebo. So we went back to non-targeted therapies, but with quite interesting results, such as in the case of lenvatinib, a drug already used against thyroid cancer. And in this case, lenvatinib was compared to sorafenib first line, not inferior to Nexavar to sorafenib, with even better results in terms of progression-free survival. The mechanism of action of lenvatinib is similar to sorafenib, but a little bit more selective. So probably with lower rate of adverse event, but we still have some important adverse events such as hypertension, decreased appetite, decreased weight loss. And in our meta-analysis, we found no difference in terms of overall survival, but we found difference in terms of progression, 1 year progression-free survival rate. The future, as I aforementioned, is about immune checkpoint inhibitors in several tumors. Also, for example, in mismatch repair deficient colorectal cancer patients, for example. These are interesting drugs. I don't know if you know the mechanism of action is quite well represented in this cartoon. Our immune system is effective against tumor. Okay, tumoral cells. You see our good soldiers with a lot of weapon against tumoral cells, but there are some checkpoints that prevent this large effect of immune cells. These drugs remove these inhibitors, these checkpoints, so our checkpoint inhibitors, so our soldiers are free to fight against tumoral cells. An interesting concept. However, the obvious consequence is the higher risk of immune-related adverse events due to the dysregulated immune system activation. Among these drugs, we have ipilimumab, nivolumab, pembrolizumab, and in the case of hepatocellular carcinoma, in particular, atezolizumab. In BRAVE trial, very interesting results, significant difference as compared to sorafenib, trial published in New England Journal of Medicine, and even better patient-reported outcomes. So these drugs are quite well tolerated because they do not create many problems in terms of liver function deterioration. Of course, we can have some problems with immune-related disease, in particular in patients with a pre-existing for example, inflammatory bowel disease or other autoimmune diseases. So these are the main key warnings, also with bevacizumab, the risk of bleeding. This is the Himalaya phase 3 trial, currently published, presented only as conference abstract at the last ASCO, American Conference of Oncology. Very important result, a 4-arm trial, and significantly superior, a different dosage, this combination of immune checkpoint inhibitors against sorafenib. And these are the other results. I go quite quickly because time passes. Overall survival significantly superior with durvalumab, another immune checkpoint inhibitor against sorafenib. Interesting, limited utility of immunotherapy in patients with non-viral, in particular with metabolic-related liver disease. We still don't know why, probably due to some different molecular pathway, but this is an interesting observation. Of note, autoimmune diseases patients were excluded from all the trials. So the real effect in this patient will be seen in real-world, real-life studies. This is a meta-analysis we published on the effect of immune checkpoint inhibitors, not only in the use of hepatocellular carcinoma, but against all tumors in patients with pre-existing inflammatory bowel disease. As you can see, up to 40% of patients experience a form of IBD relapse, so nearly half of patients. And this form was so heavy that led to treatment immune checkpoint inhibitor interruption in 35.4% of patients. These are the ongoing phase 3 trial with several forms of immunotherapies. This is the first line. Second line systemic therapies, according to guideline, the regorafenib is the drug with the wider experience after sorafenib. So in patients not tolerating or progressing after sorafenib. Again, it should be used only in patients with well-preserved liver function, childhood 8 patients. In our meta-analysis, we found in second line, median survival 11 months. It's not bad considering that we are talking about second line therapy. These are the recent ISMO HCC guidelines. Consider the right part of the diagram. First line therapy, sorafenib or lenvatinib, or where available, in Italy not yet, out of compassionate use, atezolizumab plus bevacizumab. In the case of intolerance or tumor progression after first-line therapy, after sorafenib, we can use cabozantinib, regorafenib, or ramucirumab in patients with alpha-fetoprotein level beyond 400 nanogram milliliter. Option after atezolizumab or lenvatinib, sorafenib, if not previously used, lenvatinib, cabozantinib, regorafenib, ramucirumab. So you see, we have many options now. And these are the last trial, resource trial in second-line regorafenib versus placebo, celestial trial, cabozantinib versus placebo, and the more recent trial with ramucirumab. These are some results with regorafenib. Adverse events with regorafenib are very similar to sorafenib. The overall survival from the start of systemic therapy, so first-line sorafenib, and considering also second-line regorafenib, is up to more than 2 years. So not bad, considering that these are advanced patients. And very good results are observed also with cabozantinib. Okay, we can go on quickly, so we have time for questions. Many other immune checkpoint inhibitor drugs are being tested, nivolumab, pembrolizumab. So this is a field, an evolving field. So we should, I think, update this talk in the next years to talk about newer drugs. Okay, this is in the second line, another combo therapy of immune checkpoint inhibitors, nivolumab plus ipilimumab. And objective response is more than 30% across all groups. Okay. The last concept, combine and adjuvant treatments. We could try to combine radioembolization and sorafenib, for example, try to have a synergistic effect. Theoretically, we can have this synergic effect, but we tried this combination in the clinical practice. When I was in Milan, we also published a paper. We had disappointing results, honestly. We did not find any difference. And also in our meta-analysis, we did not find any difference with the combo therapy. So it should not be recommended. The problem of recurrence, as we already talked about, recurrence rate even after curative treatment is up to 70% at 5 years, so very, very high. It's in particular intrahepatic recurrence. We should distinguish between early versus late recurrence. Early is usually in the same previously interested segment, and within 2 years. So it's the true recurrence of the previously treated nodule. A distant recurrence, in particular after 2 years, represents a de novo tumor. And the main prognostic factor upon recurrence is not the tumoral stage, because these patients undergo tumor surveillance, so usually it's an early stage, but liver function that frequently is deteriorated, as demonstrated in our study. The concept of post-recurrence survival. Several adjuvant treatments have been tested. In particular, the large STORM trial was a big failure. The use of sorafenib after radiofrequency ablation of tumor resection for HCC. It was a failure due to 2 reasons. The drug should be taken all lifelong, okay, until patient death. And so this is a problem. Second, the several adverse events, as we already saw previously, usually frequently lead to treatment discontinuation or underdosage, thus limiting the effect of the drug. Future goals in HCC, suggested by the EASL HCC panel, public health policies to prevent, detect, and treat chronic liver disease. This is fundamental. You see how many problems we should face once the diagnosis of HCC is done. So we should do our best to prevent liver cirrhosis, so to prevent HCC occurrence. Appropriate cancer surveillance to detect HCC once cirrhosis occurs. And we should try to link molecular subclasses in clinical trials to therapeutic response, the concept of targeted therapies. We still are not in line with other tumors where we have well-targeted therapies. Unfortunately, in the case of HCC, we are not. It's not the case. Thank you, with some image of my region. I hope you will come soon after this tough time, and it was a pleasure for me to have this talk with you. Thank you.
Antonio, thank you very much. This is an amazing, really great topic and covered, I think, almost totally. We have few questions in a chat. I will start with them, and after that, we can ask personally for the questions. So the first question from the chat is, in which case, in your opinion, anticoagulation should be prescribed in tumor thrombosis in a system of portal vein?
Okay, unfortunately, it's not useful at all in the case of tumoral portal vein thrombosis. In the case of portal vein thrombosis due to liver cirrhosis, okay, but with many caveats. You know, there was a meta-analysis published by an Italian group in Gastroenterology 3-4 years ago. Yes, it's useful, but we should be very, very careful. In the case of tumoral portal vein thrombosis, unfortunately, it's not usable at all. So it should not be used. It's not recommended.
Okay. So the next question is if there is any issues with the treatment of patient with the HCC BCLC more than A in non-cirrhotic liver. Any special things about?
Okay, of course, in this case, the situation is easier, lower risk of recurrence, and we can try more treatment because the risk of liver decompensation is very low. If we have, for example, a large tumor, this is usually the case because the patient not cirrhotic present a late diagnosis, okay, because it does not undergo screening. A large tumor, a huge tumoral mass, but non-cirrhotic liver, okay. In this case, we can try radioembolization, and we can try even higher doses. I did not talk about it due to time issues. In the case of TARE, radioembolization, the nuclear doctor calculate the dose. Each patient has his own dose, and the limiting factor for the dose is the liver function. If we don't have issues with liver function, we can try higher dose, so the treatment is still more effective. So in this case, this is usually the case, I will try radioembolization, or if feasible, also resection, of course. But if we have a central huge mass, resection may be a problem, so I will try radioembolization in this case.
Okay, so the third question is if patient with HCC BCLC with a thrombose in portal vein with the background of liver cirrhosis, there is a full response with the treatment atezolizumab, bevacizumab. Would you follow up this patient or consider transplantation?
So if I understand well, there was a complete response with the new treatment. Okay, no, I will not try liver transplantation in this case unless we have a long follow-up, strict follow-up without evidence of disease, because I assume if the patient started the combo therapy, it was an advanced patient, I assume. So I will be very, very careful. In the case of, I would like to stress this concept. We should be very careful with use of liver transplantation. I remember, unfortunately, a young patient when I was in Milan, very young patient, 18 years. He had an advanced disease. We tried liver transplantation because we said, oh, it's a young patient, let's try liver transplantation. He died after 3 months for tumor recurrence. So we think that we do the best for the patient, but we do the worst for the patient if we risk liver transplantation out of the indication. So we should be very, very, very careful with liver transplantation. We could try other treatment, but in the case of transplantation, we cannot try. We should be sure.
And how long would you wait?
Honestly, I don't think that a patient starting from an advanced stage could undergo liver transplantation. In my experience, it never happened. So honestly, I don't think it's feasible. I think it's a dream, but not a real thing.
Okay, okay. So we move further. Do you use systematic therapy for patient in liver transplantation waiting list? If yes, did you have any adverse events?
Okay, no, I don't have experience for the same reason. Systemic treatment is in the case of advanced patients, so 2 out of Milan criteria. We have instead experience, we also publish in Journal of Hepatology, our experience in Milan after therapy, for tumor recurrence after therapy. Prognosis was after transplantation, sorry, so recurrence after transplantation. Prognosis was still worse, but we had a significant result as compared to placebo, to no treatment. So yes, after transplantation, not in experience before transplantation.
Mm-hmm. The next question is, how do you see the role of stereotactic radiotherapy in downstage therapy of HCC patient? And thanks for a lot for an amazing talk.
I don't have experience, and I think very few centers worldwide have this experience, because it's very difficult to have a targeted external therapy, because liver cirrhosis represents a high risk for external therapy, radiotherapy. So very few centers have this experience. In highly experienced centers, yes, it's an option. But I think, for example, in Italy, I don't know very high experience centers, and honestly I will try other treatments.
Okay,
but if you have this experience, yes, you may consider.
And so who is the leader of this therapy? United States?
There is something in United States, but in particular in Eastern Asia. But honestly, I don't know why we should risk with external radiotherapy when we have other options, honestly.
Okay, so
I don't think why we should risk.
Okay, we still have some new people to join us. Do you use evaluation of liver effective parenchyma, for example, contrast MRI or other non-contrast agent in patients with the liver cirrhosis before liver resection?
Yes, there are many options. The endogenous green test that it's metabolized by the liver. So we make sure there is on the capillaries, no? Okay, and the finger, we can evaluate the metabolism of liver. So yes, there are very good tools and very easy, user-friendly tools to assess. Yes, it's absolutely recommended. Not MRI, not MRI.
So they are, but do you use them in a practice?
Yes, sure, because they are very easy. They are cheap. They are they don't have risk for the patient. So yes, why not? Yes.
Okay. What are leading etiological factors for HCC in Italy?
Sorry, can you repeat?
What are leading etiological factors
for
HCC in Italy?
In the past, HCV, now metabolic.
Metabolic.
Yes. In the past, HCV, like in Western Europe, and I don't know in your country, maybe also. And
talking about portal hypertension, PG in HCC patient, is it clinically significant? Okay. Talking about portal hypertension in HCC patient, is it clinical significant portal hypertension? You always check or clinical signs such as esophageal varices or something else?
Okay, usually yes. You probably know that there are some groups, for example, Vienna group, Barcelona group, Bologna group, that perform invasive assessment, measurement of portal pressure, vein pressure. Honestly, I don't think it's very useful. I think indirect clinical signs are effective in predicting portal hypertension, so I rely on them.
Okay, and even in advanced cirrhosis, in advanced
cirrhosis is quite clear that you have portal hypertension. So yes, but of course, yes, the clinical sign, ascites, if you have ascites, varicose bleeding, or esophageal varices, yes, sure.
Which medication do you use for patients with recurrent HCC after liver transplant?
As I told you, it's a big issue. Usually I still use sorafenib, I try sorafenib, but with very worse results. But yes.
So it's like you don't have any other choice, so it is sorafenib.
Currently, no. Currently, no. Probably in the future, we will have all the drugs that we have seen during the presentation. But as I told you, due to the immune suppression after liver transplantation, it's a problem. In the case of liver recurrence, not after transplantation, yes, we are in the general situation. So in that case, we have many options. Yes, I start in general in advanced patient. I start with sorafenib. I still start with sorafenib. Then I move to the second line therapy.
And if we talk about patient logistic, let's say in Italy, how it works. I mean, here in Russia, we have to, for example, if we diagnose patient with the HCC, we need to refer this patient to oncologist, and oncologist make a decision what to treat and how to treat. And how it works in Italy. Can you do all these procedures by you, or there is a team and you say we're going to do that or this? How you make?
No, in Italy, the HCC patient is in charge of the hepatologist. Mm-hmm. And I think it's the correct, because the hepatology has a complete landscape, no, of the situation, liver function, cirrhosis, and so on, not the oncologist. So no, there are some oncologist experts in HCC, but in very few cases, it's the hepatologist that treat this patient.
Okay. How often do you go against BCLC criteria, especially in the BCLC-D patient?
So the question is when.
How often do you go? Let's move to the next question, and we will maybe. Could you please write it down in Russian? Do level of alpha fetoprotein influence on your choice of treatment? No. Do you use combination of TAHI and system therapy for downstage?
Systemic therapy and the other therapy?
And TAHE, TACE.
Okay, yeah. TACE. In the, before, when? In the...
For downstage.
For downstage, so before. I don't use systemic therapy for in downstage, so only TACE. TACE or radiofrequency ablation or microwave, so ablative therapy.
Yeah, we're waiting for comments on this question. And in your practice, is there any difference in treatment and course of disease between different etiology beyond HCC? Like HCV patients are doing well, and NASH patients are having worse prognosis?
Yes, we observed from the 10 years ago that probably NAFLD patients, NASH patients with HCC have a longer course of the disease. Not a better, yes, longer survival. The final outcome is the same, but they need more time to that or to the other event. So probably there is a difference. In the case of viral etiology, in the era before effective antiviral therapies, we have a quicker course, clinical course, yeah.
And how often do you see a patient with some different etiology, like gamma-chromatosis or Wilson disease with the HHCC?
Not common.
Not common. In general. Okay. And the question was, can you modify treatment when you speak about patient with the when you treat patients with the BCLC-D, for instance, like there is a insurance covering and you cannot do anything beyond, or there is a place for playing or a place for any last chance treatment?
So in BCLC-D patient.
Yeah.
Okay, likely in Italy and in many European countries, we don't have issues with insurance, so we can do whatever we want and whatever our conscience tell us to do. Of course, you cannot do many things in these patients. We try a supportive therapies with some hormonal therapy, for example, megasteron, Megace, the clinical name, but with very, very worse results. So we cannot do anything in these patients, honestly. Anything effective.
Okay. So I think we finished with the, no. What is the main criteria to stop TACI in a certain patient?
Okay. According to the guidelines, we should try 2 TACE sessions. We are talking about TACE, yes?
Mm-hmm. Yeah.
2 TACE sessions. And if we don't have a complete response, we should switch to another therapy, radioembolization or other therapies. As you saw in my presentation, several groups proposed some clinical score. Some of them was validated, externally validated, some other not. That was the most important, the art score, but there are also other scores. I remember a score proposed by a French group. It's an individualized choice, honestly, an individualized choice. According to the guidelines, you should try twice with this.
And in your practice, how do you usually?
In my practice, it depends. I select patients beforehand. If I have a patient, like in the picture I show you about radioembolization, a huge mass, you will never reach a complete response with TACE, even after 10 TACE sessions. So I immediately go to radioembolization. If I start TACE, is because I know, based on my experience, that that patient will respond to TACE. So usually not frequently in the case to switch to another therapy. If I do TACE, it's because I know that I can achieve a complete response with TACE in a couple of sessions, no more.
Okay. Could the contrast CT be a method for recurrent screening instead of MRI?
Both are effective. Maybe MRI can be a little better, but it depends on the expertise. Both are effective. Let's say that both are effective.
So the same.
Yes, yes.
Okay, so we have many things in chat, and I think we finished with the questions. Maybe some of our colleagues would like to ask in a voicemail. Any questions? Okay, so
okay.
So it was amazing, very interesting, and pictures of your beautiful country is truly exciting. We are looking forward to visit you one day.
I wish so. I wish so. Thank you for the invitation. I'm very glad that you have this good group, good club, and I wish you all the best for your And I'm open to collaboration if anybody of you is interested, of course.
Okay, if you don't mind, we made a record of this presentation, and we'll share it afterwards.
You can share my email. You have my email with the other, if you want.
We will do it. Thank you very much, Antonio.
Okay, thank you.
Thank you, colleagues.
Thank you. Thank you. Thank you.
Have a nice evening.
You too. Bye.
Bye-bye.
Bye.